breast cancer. These things on the list here, deodorants, your underwire bras, injuries to the breast, and of course contagion. I've not even heard of that one myself, but several of these myths have circulated about, or perhaps you've seen an email talking about these things, but there's never been a statistical study bearing out that there is a direct relation between any of the usage of these products and development of breast cancer. So as far as prevention, these are just sort of things you can do to minimize the likelihood of developing breast cancer. A healthy lifestyle, which of course is good across the board to aim for. Exercise and diet, of course, lots of fruits and vegetables with antioxidants to minimize cancer risk in general. Maintaining a normal weight, which also relates to the next, which is avoiding taking unnecessary hormones, because again, if you maintain a normal weight, that keeps hormone levels balanced and will not abnormally increase estrogen, which, as we mentioned before, excess estrogen levels can increase breast cancer risk. And then avoiding unnecessary or excessive X-rays or radiation exposure, because excessive radiation to the chest can also increase breast cancer risk. So that's what we're up against. Breast cancer, that is what we're hunting for. That's what we're looking for so that we can detect it as early as possible, treat it most effectively, and of course produce the best benefit and survival for the patients who are affected. So how do we find it? The two main ways are physical exam, meaning that either the patient or the patient's physician has felt a lump or identified perhaps changes in the skin of the breast, or maybe even a bloody nipple discharge, something along those lines, a change in the patient's breast. And then of course where I come in is the imaging, meaning taking pictures of the breast, another way that we detect breast cancer, and speaking specifically, or beginning with anyway, mammography is primarily in one of two categories. It's either screening or diagnostic, and we'll talk about that a little more as we progress through the presentation here. Breast imaging. There are a few modalities, we call them, ways that we take pictures of the breast. Here are three of the most common, with the top two being the heavy lifters in the breast imaging world. The top, mammography, of course, then ultrasound, which while many people associate ultrasound, which is pictures being taken with sound waves, as being used to take pictures of babies, which we do use that for that, it is also very important in terms of imaging the breast as well. And MRI being the third, which is magnetic resonance imaging. So to break those down a little bit, we'll talk about each of those in turn. So at the top of the list, as I mentioned before, is mammography. It is the screening gold standard. This is taking pictures of the breast using X-rays, and some of the advantages and disadvantages we'll look at a little bit here. Advantages, of course, cost effectiveness. Mammography is one of the cheapest ways to get an idea of general breast health, which is most important in the asymptomatic population as far as screening, meaning we're looking out in the population to detect unsuspected breast cancer. Another advantage of mammography is accessibility, and many institutions actually have mobile coaches or mobile vans that they send out into the community to be able to provide this service to larger geographical areas and increase patients' ability to obtain the service. Another great thing about mammography is that the two pictures that are included in a mammo exam, we take two pictures of the breast, a top-to-bottom picture and a side-to-side picture. We'll show you some examples a little later. They allow for a whole breast survey, meaning with those two pictures you can see the entire breast, the majority of it anyway, that you can actually get onto the picture, and we work very hard at that as some of you ladies may be familiar with the tugging that you experience when you have your mammogram. But it allows us to get an entire picture of the breast and give us the best chance at detecting any early breast cancer. Disadvantages. Compression is number one. I'm sure that's one of the things that comes to mind almost immediately when a woman thinks about a mammogram. And while that may be considered a disadvantage from the experiential side as far as undergoing your mammogram, I have to admit to you that from the side of a physician interpreting a mammogram, compression is of the utmost importance, and I thank you ladies in advance for enduring it, because it can make all the difference as far as spreading out the tissues, allowing us to get the best picture of the breast and not allow a tiny breast cancer to hide somewhere in the glandular tissue because we didn't compress the breast as much as necessary to get an optimal exam. Then there are, of course, technical limitations, as with anything. Positioning, of course, and size of the breast, etc. The next major player in terms of breast imaging is ultrasound. Again, I mentioned that's taking pictures with sound waves. It's crucial for the evaluation of masses or lumps and densities, which are areas that we see on mammogram, which stand out a little from the rest of the breast tissue and just suggest that they might need a little extra attention. Advantages of ultrasound. It involves no radiation. As I mentioned before, the pictures are taken with sound waves, so this makes this type of imaging particularly attractive in use with young patients, patients under 30, and obstetrical patients, pregnant patients. It's also fairly quick, and it gives us real-time information, meaning once we have put that goop absolutely everywhere possible, as anyone who has had an ultrasound knows, then actually the area that either the ultrasound tech or the physician is scanning over with the transducer at that time, we're getting real-time information about that particular portion of the breast at that particular point in time, which can be extremely valuable. Disadvantages. It is operator dependent, meaning that the pictures that are recorded at the time of an ultrasound are those that the person doing the exam takes, meaning they are just taking representative pictures, or they see something abnormal and they take the pictures. So it's like a photographer. If the person doing the study, they only take pictures of what they see. So if they don't see an abnormality, they won't take a picture of it, there won't be a record of it. And that's the interoperator changes that can occur, but the important thing is that you have a skilled and knowledgeable ultrasound tech and physician performing and interpreting the exam, which of course is what we provide for you here at Kelsey. False positives are a possibility as well. Breast tissue is extremely dynamic. Changes can occur based on hormonal changes from week to week or month to month. And so, again, it's important that the ultrasound technologist and the physician performing the exam and interpreting the exam are familiar with those changes and the nuances of evaluating breast tissue sonographically to give the best and most accurate interpretation possible. The third on the list is MRI, which serves mainly as an adjunct imaging modality, problem solving, and staging, meaning MRI is often used in ladies who've been newly diagnosed with breast cancer to look for additional or unexpected areas of cancer in the same breast where the breast cancer has been detected, or unexpected areas in the opposite breast. And that also is in the advantages. That is an advantage of MRI in terms of breast imaging. And evaluating implants. MRI is uniquely suited for evaluating possible rupture or leakage of implants, and is actually the go-to exam for that purpose. Disadvantages of MRI are that it is expensive and can also lead to false positives. MRI is extremely sensitive, meaning several things may show up on the MRI but it is not particularly specific, meaning the areas may show up, but it can sometimes be difficult to discern exactly what the areas mean or exactly what should be done with them on occasion. We can usually tell, but sometimes it can be difficult because, as I mentioned before, it's very, very sensitive, but sometimes some of the things that fall out, you're not exactly sure which category they belong in, and so that can sometimes be something a little challenging to manage. But again, that's why MRI is sort of a special case used for problem solving and has to be used in conjunction with both ultrasound and mammography to give the best exam and care possible. So let's chat a little bit. So we've talked already about what we're looking for, which is breast cancer. And then we talked a bit about the tools that we have to use in our search for breast cancer, meaning the imaging modalities, primarily mammography and ultrasound, and on occasion, in special or carefully selected cases, MRI. So how do we use them all? I'll take this time to sort of lead you all down the yellow brick road, so to speak. And so if we're heading down the yellow brick road, I guess that means that I'm the representative of the Lollipop Gang, inviting all of you or welcoming all of you to Mammoland. So we'll start, most people begin their journey with a screening mammogram. That's usually the asymptomatic population. People coming in have no difficulty or symptoms that are related to their breasts and come in simply for a checkup. So there are two main outcomes, possibilities for screening mammography. If the exam is normal, fabulous. We'll see you next year, or whichever screening interval you and your physician have discussed is optimal for you. If the mammogram is abnormal, then we'll see you next week, meaning you need to come back because there's something that we can't be absolutely sure is completely benign and safe for you to go another year or whatever your screening interval is. We want to have you come back, make sure that we're not missing anything, so we want you to come back and have a little more imaging, take a few more pictures, make sure that we're seeing everything necessary. So the pictures when you come back are called a diagnostic mammogram. We take some extra pictures, and the main reasons for a diagnostic mammogram, meaning the abnormalities that we see on this screening mammogram, the first study, that we bring you back for are densities, which I mentioned before, little areas of tissue that stand out, which of these does not belong sort of thing, an actual mass, something that is visible on each of the two views of the breast so that you know something is there that doesn't belong. We need to evaluate that a little more, figure out what it is and what further management is necessary. Or calcifications, which are small deposits of calcium which can on occasion be associated with early breast cancer. Two main possible outcomes for the diagnostic mammogram are, of course, a normal or benign result or an abnormal result. So after the diagnostic mammogram, if we do the extra studies, which might be extra compression, which I know all of you love, an extra added area that we press even harder than we did on your first mammogram, but it's directed to a particular area of abnormality that we saw on the screening study. If that turns out to be normal or a characteristically benign finding, fine, we'll see you next year. If it continues to be abnormal, and some of the possibilities I've listed just below that, some of the abnormal outcomes that might persist after you've had your second mammographic evaluation is a mass, as I mentioned before, a lump or something that is clearly visible on both of the pictures of the mammogram, or a density, an area of tissue that persists. The next study to be done for further evaluation is the ultrasound exam. Possible outcomes for the ultrasound I mentioned there are benign, something like a cyst. Follow-up, meaning, yes, we see something here that matches the area we saw on the mammogram, but it's not overly suspicious. We'll just have you come back In 6 months, we just want to make sure nothing is going to change in this area, but we're not overly concerned at present. This is 98% normal. Or the other possibility, of course, is this area is not normal. It's possible something is going on here that needs some extra attention, and at that point we'd recommend a biopsy. Another possibility for a reason for the diagnostic mammogram to be abnormal is, as I mentioned before, calcifications. And when we evaluate those further, we take pictures where we magnify them and take a better look at them. We can discover that they're characteristically benign calcifications. However, we're usually able to discern that at the time of screening mammography. But once we do a diagnostic mammogram and look at the magnified images of the calcifications, the two main possibilities that come out from that are that these are probably benign. Again, 98% sure that these are nothing to be worried about, but just in case, we're going to ask you to come back in 6 months to make sure that we're erring on the side of caution, make sure nothing changes, and we stay on top of this. Or we look at it and say, well, the way these are arranged, we're not so sure that these are anything benign, and they actually might be something a bit more serious, so the appearance is indeterminate or suspicious, and then the recommendation would be to do a biopsy. So that's a little, as I mentioned before, we started with talking about breast cancer, which is what we're looking for. We talked about the tools we have to use in our search, and then the way we go about our search. So now we'll look at a few examples. Here are two examples of mammograms. I'm going to use my cursor here. The one here on the left is what we consider fatty breast tissue, meaning the gray here is fatty tissue and the wisps of white scattered about are the glandular tissue. And all breasts are made up of these components. It can just vary whether you have the majority fatty tissue or, like the breast on this side, majority glandular tissue. Much more dense, much more white you see here, much more glandular tissue. But these are the two types of pictures we take. The top to bottom picture is on this side, the side to side picture on this side, and that gives us, we add these together and it gives us the three-dimensional picture of the breast that allows us to get a whole breast survey. Right side here, left side here. But as you can imagine, having the greater concentration of glandular tissue here can make this a more challenging exam to interpret, and compression becomes very important here to spread out this glandular tissue so that a small breast cancer can't hide behind the glandular tissues in the breast here. So here's an example of a patient who came in for a screening mammogram, no problems with her breast, and there's a circle here showing an area of calcifications that we discovered on the screening mammogram that was abnormal. So that's screening mammogram, abnormal. We ask the patient to come back for a diagnostic mammogram. We take a magnified picture of this area, and then right back here there are little dots of calcification progressing in a line back toward, this is the patient's chest wall, the pectoral muscle here, way at the back. And there's a line of little dots and dashes of calcifications here which are not normal and are suspicious for cancer. So the next recommendation is for biopsy. This is a picture here. The patient is undergoing a stereotactic biopsy, meaning a biopsy performed using x-rays, since that's the way these calcifications have to be seen. They're visible by x-rays and not so much by sonography. This is the needle, and we're aiming for the calcifications in here. When we do this kind of exam, aiming for calcifications, we take a picture of the samples themselves to confirm that we've obtained the calcifications in our sample. That verifies the accuracy of our biopsy. These are the calcifications here, so we did get what we were aiming for. And at the end of the study, we place a little metallic clip at the biopsy site so that if any additional intervention is needed in this area, we know where to revisit. This was ductal carcinoma in situ. This was early breast cancer. We'll move quickly through the rest of these cases because our time is drawing to an end. This is a patient with more dense breast tissue. She actually had a palpable lump in her left breast here where the circle is. We took an extra picture. There's a subtle little round area here that we can see. This BB marks the area that the patient could feel in her breast. We did an ultrasound. This is a cyst. The dark in the middle is fluid. This is a simple cyst, benign. We subsequently put a needle inside of the cyst and drain the fluid. Poof, gone like magic. There's magic in Oz. So this, again, is another example of a patient screening mammogram. We saw a little nodule on the left side. Asked her to come back for extra pictures. The nodule still stays. It goes away, so it's real. We did an ultrasound and see a dark abnormal mass in her breast. This is the needle. We did the biopsy. This was invasive ductal cancer. Another patient here. We look for areas of asymmetry, something that doesn't belong. These two little spider-looking areas in the outside portion of her right breast are different from the left side. We asked her to undergo some additional pictures, which we still see here. They're still there. We did an ultrasound, saw the dark areas here, which are abnormal. On biopsy, that's invasive ductal carcinoma. One last patient with dense breasts. She came in because she felt a lump. There was nothing particularly of note on her mammogram. We even did the extra picture. Nothing really stands out. But with palpable lumps, it's important to undergo ultrasound, even if mammography is negative. We did an ultrasound here, and there's an area here which stands out from the adjacent breast tissue. We did a biopsy, and this was invasive ductal carcinoma. So it's important to be familiar with your breasts, and if you detect a palpable lump, make sure you notify your physician. So we'll open the floor for questions. I thank you all for listening, and let's look for questions, which are numerous. We'll do our best to get to as many of these as we can. At what age, one of the questions is, at what age should you get a mammogram? I know that there have been varied recommendations coming out in the news, etc. The best answer is for you to have a discussion with either your primary care physician or OB-GYN to determine what is best for you, because there are various risk assessment models. One of those is the Gale model. There are a few others that are out there, and it may vary the one that your physician chooses to employ to decide when you should start, because depending on whether you have a family history, someone in your family who has had breast cancer, you may need to start screening earlier, or if you don't, you may want to start at 40. Some people may want to start at 50. Again, it's a personal decision. You have to use information that's been provided regarding recommendations, and then, as with any other aspect of your health, decide which works best for you. Give me a moment here while I peruse some of the other questions and do my best to touch on these. Some of the questions are similar as far as what age should you have them, what age. Typical signs. What are typical signs of breast cancer in men? Very similar to signs in females, actually. A palpable lump. However, the most common outcome for a palpable lump in a male is benign gynecomastia, meaning they just have a little overgrowth of breast tissue, which can be due to some medications, some dietary supplements, etc. But the overwhelming, most common sign of breast cancer in a male is a palpable lump, even though the majority of palpable lumps in males are a benign outcome. But if there are any males in your life that you know have a palpable breast lump, they should definitely bring that to the attention of their physician. Is it necessary to place chips in the breast after a biopsy? Does it cause problems in the breast? It depends on the type of biopsy that you're undergoing, whether or not placement of a metallic marker is needed. As I mentioned, with the stereotactic biopsy, or there's some forms of ultrasound biopsy that we perform where we actually remove all that we can see of the lesion, it's important in those cases to place the marker, simply because if you don't leave anything behind, you don't know where the area used to be. And if it's a benign result, great, except in the future you don't know where you've already had a biopsy. And then, of course, the worst case scenario is if it comes back cancer and the entire thing is gone, where is your surgeon left as far as how best to treat you and do minimal resection as far as treatment of the cancer when we've left nothing behind to indicate where that cancerous sample came from in your breast. Does it cause problems? You can never say never, because everyone is different as far as reactions to materials, etc. But for over 99% of the population, no, there is no difficulty. The metals that are used for the clips are inert. Some of them are surrounded by collagen, which aids in healing and minimizing complications, but most people have no difficulty with the clips. Love the high heel on the mammo slide. I loved it too. Thanks for the comment on that. What is the difference between breast cancer and DCIS? DCIS is breast cancer. It is the earliest form of breast cancer. The acronym is ductal carcinoma in situ, meaning it's the earliest form of breast cancer which is still confined to the ducts and tubules in the glandular tissue of your breast. It has not broken out. It has not yet created a mass that's invading and spreading. There are rare types of aggressive DCIS that can do exactly that, but they are extremely rare. But again, DCIS, that is breast cancer. It's just not invasive breast cancer. It hasn't broken into the other tissues of the breast. It is, because it's confined in that manner, it is easier to confine and treat and effectively cure, as opposed to invasive cancers that are spreading into other portions of the breast, may need either a wider resection or mastectomy, and can of course spread to lymph nodes. Okay, we'll take one more question because our time is running out here. How is a biopsy performed? It depends on the type of biopsy. The two main means of performing biopsies are either stereotactic, which I showed you an example of, which is primarily used for calcifications, or occasionally a density on mammogram for which we couldn't find an ultrasound correlate. If we're able, and then the other way that we most commonly do breast biopsies is using ultrasound, using sound waves. We lean toward that one because it's quicker, the positioning is a little more comfortable for the patients, and as long as we can see the abnormality on ultrasound, that is usually the type of biopsy we lean toward. But of course the calcifications are best seen mammographically, and so they're biopsied using a stereotactic device which uses x-rays, mammogram pictures, to perform the biopsy. So I want to thank you all for tuning in today. I appreciate your listening, and I hope you found this useful and helpful.
All right, thank you so much to Dr. Brown for presenting today. I hope everybody got to learn something new about breast cancer diagnosis. We actually have another webinar for KSC employees, and it's coming up on October 17th. Dr. Jamal Bullocks, our new plastic surgeon, is going to be presenting for BRA Day, which is Breast Reconstruction Awareness Day. And we'll be sending out an official notice about that very soon, but we do know it's going to be on October 17th at noon, so stay tuned to register for that. And next month, we're going to be talking about diabetes with Dr. Sims of our Pasadena clinic. So if you want to go ahead and register for that, you can go to Kelsey-Seybold.com/webinars, and we do hope you'll join us next month. Thank you so much.